Alright, sorry for being a bit late. Busy time in LICU. Okay, alright, fine. Let's proceed. Let's begin our session with Umur Kitab Al-Fatihah. Okay, so let's begin our session.
Should I start present now, Doctor?
Yes, proceed.
Okay. Okay. Can you guys see my screen?
Yes.
Oh, okay. So, Assalamualaikum warahmatullahi wabarakatuh. My name is Nurlaili Nazifa, and today I'll be presenting about Kawasaki disease. Okay, so Kawasaki disease is also known as the mucocutaneous lymph node syndrome, and it is actually a systemic vasculitis which commonly affects the coronary artery, and it usually affects younger age kids from 6 months to 4 years old, and is more common in Asian kids compared to Caucasian kids. And young infants will be affected more severe compared to older children, and they will be presented with what we call incomplete cases. And later I'll explain what does it mean with incomplete cases. The pathophysiology of this disease is actually not quite understand yet, but it is believed that it is the result of the immune hyperreactivity to a variety of triggers and in a genetically susceptible host, because there is a research that said children with siblings that have this disease have higher risk in contracting this disease. And the gene that is associated with this disease is the ITP-KC gene, which there is a mutation in the gene. The mortality rate of this disease is quite low, which is about 1 to 2%. And usually the death is due to the cardiac complication that the patient get from this disease. Okay, so this Kawasaki disease, there is no diagnostic test to confirm that whether the child has this disease or not, but it is diagnosed by where the patient have fever for more than 5 days, and they have these classical clinical features, 4 out of these 5 features. The first one is the bilateral non-purulent conjunctivitis, mucosal changes of the oropharynx, changes in the extremities, especially in the hands, edema of the hand and feet, rash, and also cervical lymphadenopathy. Okay, so these types of presentation is usually can be seen in patient with this disease, where in the first week they will have fever that lasts for more than 5 days, and it is usually not treatable with antibiotics. And along with the fevers in the first week, the child will have conjunctival infection, mucous membrane changes, where they will have pharyngeal injection, red, dry, cracked lips, and also strawberry tongue. They will also have cervical lymphadenopathy. And for the next weeks, second weeks onward, they will also presented with rash and red and adenomatous palm and so, and also peeling of the fingers, around the fingers. And the complication can be seen in the 3rd weeks, where usually the complication is coronary aneurysm, and it is usually silent, but you can detect it by the cardiovascular signs such as the signs from myocarditis and pericarditis. But we also will need to do echocardiogram in this patient so that we can visualize the heart. Okay, so this is classical clinical features that can be seen with patient on Kawasaki disease. The fever is usually high, and they will comes with red lips and red tongue, which we call strawberry tongue, and also rash involving much of the body, and the rash is usually polymorphous, and the red swollen hand and feet, and also the red bloodshot eyes due to the conjunctival infection. Okay, so this other than the classical clinical findings, you can also find additional findings in this patient, such as irritability and induration at the BCG vaccination site, perianal excoriation, transient arthritis, abdominal signs such as diarrhea, vomiting and pain, hepatosplenomegaly, hydrops of gallbladder, and also sterile pyuria. Yeah, so this for the incomplete Kawasaki disease, it means that the child, they have a prolonged unexplained fever. Like I said, fever for more than 5 days, but there has fewer than 4 of the principal clinical features that I mentioned before, where they can come with 3 or 2 clinical features, and that is usually will be considered as incomplete Kawasaki disease. Okay, so for investigation, since there is no diagnostic test, but we can do some investigation to monitor the disease, and also to see the complication, especially with echocardiogram. Every child with Kawasaki disease, the physician need to do ecocardiogram to monitor the complication, which is the coronary aneurysm. And other than that, can also do full blood count, where you can see the child will be anemic, and the white blood cell will increase, platelet will increase, and the ESR and CRP are usually elevated, indicating that there is some kind of inflammation going on in the body. And you may do serum albumin, urine, and also chest X-ray or ECG. And echo is also indicated in a patient that have prolonged fever but not diagnosed with Kawasaki disease, but they comes with prolonged fever and 2 other criteria of Kawasaki disease: subsequent unexplained periungual desquamation, where they have periungual desquamation, and also 2 criteria, and thrombocytosis.
Apa ni?
and
What
rash.
is periungual desquamation?
Dia macam kulit dia tercabut-cabut dekat kuku. Apa dia panggil?
So periungual is peri beside your nail. So dekat tips of the fingers tu, desquamation maknanya apa? Kulit dia macam mengupas kulit tu. Itulah macam when the skin is dry, kan? You nampak kulit melepas. So those are periungual desquamation.
Okay, itulah periungual desquamation. And also if the patient comes with prolonged fever and rash without any other explanation. So echo is indicated in this patient. Okay, so for complications, as I said, usually patient will have a coronary artery aneurysm, and since this aneurysm is usually silent, it will cause sudden death in the baby. Thus, follow-up is usually indicated in patient with Kawasaki disease, and depends on the complication that they contracted. Follow-up can be for like 5 years interval, or they might be need to follow up for annually. Okay, so for treatment, I won't go to detail about this, but usually for treatment, patient with Kawasaki disease will be given intravenous immunoglobulin for the first 10 days, and also aspirin. This which aspirin is to reduce the risk of thrombosis, and the dosage is also changes throughout the treatment, which initially it will be given in high anti-inflammatory dosage until the fever subsides, and also the inflammatory markers, which is the ESR and CRP, return to normal, and it will then be continued at a low antiplatelet dose until echocardiography at 6 weeks reveal the presence or absence of aneurysm. Can also give antiplatelet aggregation agent if the platelet is very high. And for children with a giant coronary artery aneurysm, we might prescribe with long-term warfarin therapy and close follow-up for these kids to monitor the aneurysm. And if the fever recurs, second dose of IVIG, intravenous immunoglobulin, and infliximab, steroid or cyclosporin might be prescribed for this patient. Okay, so this is the follow-up that the patient need to follow after this disease, and it depends on the risk level of the patient, where level 1 is with no coronary artery changes, and level 4 is with coronary artery obstruction. And the follow-up will also be different. As you can see, there is at 5 years intervals, 3 to 5 years intervals, or annual follow-up. So it depends on the risk level. You can read this later this is from CPG formulation. Okay, so for prognosis, usually children will have complete recovery, and most of patients that have aneurysm will resolve, but that is for small aneurysm of 3 to 5 millimeter. For if the aneurysm is more than 8 millimeter in diameter, the prognosis might be worse, and the mortality, like I said, is 1 to 2%, and usually from cardiac complication. Okay, so yeah, so for vaccination, for kids that is treated with the immunoglobulin, vaccination, especially for live attenuated virus vaccine, need to be delayed for at least 11 months, because the use of the immunoglobulin will impair the efficacy of the vaccine. Okay, so that's all. This is my reference. Is there any questions?
Anyone? Any issues? Kawasaki disease is among favorite question for exam. Can it come up in clinical exam?
Okay.
Cannot.
Clinical, okay.
Usually no lah, usually no.
Oh.
Because usually when the patient comes at the very beginning, the child is usually very unwell, high grade fever. So usually the child is unwell. So we won't put unwell patients for clinical exam. The moment the child is well, afebrile, that moment there's no more clinical signs anymore. So usually we don't give lah, because there's no signs. Just based on history, it's a bit difficult. But if we do exam in HTAA, probably if we do have one Kawasaki, sometimes we can bring you for exam lah. But one thing I need to remind, Kawasaki always comes up as theory exam. So part of theory exam, Kawasaki is among the favorite question lah, because there's so many things that we can discuss.
Okay.
Okay, all right, fine. Any other question?
Hello.
I have a question. Or a bit have a question too.
Sila.
Okay. My question. You said that the indication for echocardiography, it has to be the patient must have two other criteria. Does that mean that two other criteria is other than those principal principal features? I mean the irritability, erythema.
No. For children with Kawasaki disease that have fever and four of the five classical features, they will have to do echocardiography. But for children that have prolonged fever but do not have four classical features, but instead they only have two, that children also need to, the physician needs to do echocardiography on that patient too.
Also have to do it to everyone. I mean,
not everyone. Those with the features that I've mentioned before lah.
The first five. Is it the first five clinical features? Bilateral, cervical lymphadenopathy?
Yes.
Oh, okay.
Yes.
Okay.
It's not that complicated. So basically, if they fulfill the enough criteria, you can diagnose easily. But those patients who have prolonged fever doesn't have the full criteria for Kawasaki disease, or they don't, like, the fever is not yet 5 days, but there are other subtle signs of Kawasaki. If you think there is Kawasaki, there's two out of all the 5, then you just do echo. Because I think nowadays most of the Kawasaki disease we diagnose is actually those atypical Kawasaki or incomplete Kawasaki disease. So this is, I think, the most of the diagnosis now is like that. So you just need to have high index of suspicion. Do we do echo on all? Obviously we do not do. There's not many pediatricians that can do echo. Like in Susmed, only Dr. Taufik does echo. The others konon-konon je boleh buat echo, but only Dr. Taufik yang buat echo. In HTA a bit more lah, but mainly it should be Dr. Amir. So there's not many pediatric. We don't have that many pediatric cardiologists in Malaysia. So those that you think there is, you just need to have high index of suspicion. Okay, all right.
Thank you,
Fine. Okay, proceed.
I have one question. You mentioned in the beginning, you said that the cause of Kawasaki is the result of immune hyperreactivity to a variety of triggers. So my question is, in a patient with Kawasaki disease, can you find like a specific causative organism that cause the hyperreactivity, or is it like completely autoimmune?
From what I read, it is there is no triggers. Bukan no triggers. No identified triggers, but it usually related also to the genetic, because there is a research where the patient with siblings that have Kawasaki disease, then they have higher risk to contract this disease. But the triggers is, I'm not sure. There's no definite triggers that you can say, oh, this caused Kawasaki disease.
Okay, thank you.
Proceed.
Next presenter should be Nurin, Tengku Nurin.
Can you see my slide?
Yes.
My name, Assalamualaikum warahmatullahi wabarakatuh. My name is Tengku Nurin Nadira. I will be presenting about scarlet fever and acute rheumatic fever. So this is the outline of my presentation, which I will start with scarlet fever, and then we will proceed with acute rheumatic fever. And then, so scarlet fever. So scarlet itself means red, and scarlet fever also known as scarlatina, and it is a diffuse erythematous eruption that generally occur in association with exudative pharyngitis and fever. So it can affect all age group. It also can occur in adult, but it predominantly affect children aged 5 to 15 years old, and it is uncommon in children aged 3 years and younger. And because of this disease, scarlet fever, it occur due to the infectious agent streptococcal pathogens. So the transmission can occur. The transmission can occur through airborne respiratory particle. For example, when the infected person sneezing or coughing, so they can spread the infectious agent. And the transmission also can occur through fomites when the person touch the any any things with droplet on it, and then they touch their mouth or nose, and also when there's touching sore on the skin. And for the risk factor, include close contact with another person with scarlet fever, and also crowded place such as school or daycare center, because this infectious agent can spread more easily, and also poor sanitation. So this explains why this scarlet fever has high prevalence in the underdeveloped or developing countries. And then scarlet fever, it is caused by streptococcal pyrogenic exotoxin, which is produced by group A beta hemolytic streptococci, which specifically we refer to the streptococcal pyogenes, which is a gram-positive bacteria. So generally, all streptococcal pyogenes, they can, by the natural mechanism, they cannot cause scarlet fever. But because they require a gene to encode for the exotoxin, for the streptococcal pyrogenic exotoxin through lysogenic conversion. So through lysogenic conversion. So we have this is due to the bacteriophage. We have a bacteriophage, which is this bacteriophage. It is a virus that infect bacteria. So when they infect the bacteria, which in this case is streptococcal pyogen, they attach to this bacteria and then they inject their DNA into this bacteria cytoplasm. So their DNA will combine with the bacterial DNA, bacterial chromosome, which then will produce prophage. So now this streptococcal pyogen now they have the gene that can encode for this exotoxin. So they will produce and release streptococci pyrogenic exotoxin (SPE). So we will have SPEA, SPEB, and SPEC, and all of these SPE are super antigen. Talking about super antigen it is very powerful. So because they can directly bind laterally to the MHC class 2 on the APC and also the variable beta region of the T cell receptor. So when they can bind directly, so they can cause overstimulation and also overactivation of T cell. So when there's overactivation of T cell, there will be high production of inflammatory mediators. There will be a lot of inflammatory mediators. For example, cytokine like interleukin 1, interleukin 6, interleukin 2, TNF alpha, interferon gamma. So this will lead to high intensity of inflammatory response. And one of the inflammatory response that we learned before is there will be dilatation of blood vessel. So this dilatation of blood vessel will lead to the characteristic of scarlet color of the rash. The rash will become red, erythematous eruption. Okay, so patient usually it will take 2 to 5 days for patient who is exposed to the group A streptococcal to become sick. Initially they will present with high grade fever associated with chill, and then there will be sore throat and tonsillar exudate where the throat and the tonsil may be very red and also sore, and then they will have tender anterior cervical lymphadenopathy, and they also present with whitish coated tongue, and the tongue will appear swollen, and later this white coating can dissolve and the papule will remain, which will give rise to the strawberry tongue, which this strawberry tongue it is red and bumpy, and patient also can present with headache and malaise and also nausea, vomiting. They also have circumoral failure and flushed cheek. So this is the example of what I had said before. This is the whitish coated tongue, strawberry tongue, circumoral area with flushed cheek. Okay, so this is the important clinical presentation in scarlet fever. They will have erythematous rash. So this rash can appear 12 to 48 hours after the onset of fever. And first, they will appear on the neck, underarm, and groin. And then they will extend to the trunk and extremities. And usually they will start as a small flat blotches, and then there will be a fine bump, peculiar elevation, which this gives rise to the sandpaper-like rash. This is a sandpaper-like rash, which can be seen in the scarlet fever. And the rash is most marked in the skin fold, like inguinal, axillary, antecubital fossa, and they can form a linear petechial character at the skin fold. We call it Pastias line. So this is the Pastias line, and after about 7 days, this rash can resolve, faded, and they will present with. After that, they will present with desquamation. So, okay. So, if this scarlet fever or this infection are not treated properly, so it will give rise to complication. So they will have suppurative complication as well as non-suppurative complication. Suppurative complication, for example, peritonsillar, pharyngeal abscess, otitis media, sinusitis, and so on. And for non-suppurative, there will be acute rheumatic fever, post-streptococcal reactive arthritis, and also acute glomerulonephritis. So this is how we want to evaluate and diagnose scarlet fever, and usually the diagnosis mostly based on the clinical manifestation and also some of the laboratory tests to support. And we will look for the sign and symptom that I had said before, and also the risk factor, and we will assess for this center criteria. We have and each of these criteria will give us 1 mark. For example, if the patient had fever, 1 mark, anterior cervical lymphadenopathy, 1 mark, and then and so on. And if uh, the uh, 0 to 1, they are unlikely to have a group A streptococcal infection, and for mark 4 and above, they are most likely to have the group A streptococcal infection. And other tests that we can do is throat and nasal culture to prove the presence of this infectious agent, and then rapid streptococcal test, serologic test to detect antibody such as anti-streptolysin O, anti-deoxyribonucleases B, anti-hyaluronidase, and so on. And also we can do complete blood count where usually there will be leukocytosis with predominantly neutrophil, and also inflammatory marker like CRP, C-reactive protein, and also ESR will rise, and liver function test and urinalysis may reveal changes associated with complication of scarlet fever. So for the treatment and management, usually patient will be given oral penicillin or amoxicillin as the first line drug, and if the patient have allergic to the penicillin, we will give them first generation cephalosporin, and the course of treatment will be 10 to 14 days, and the clinical improvement should be noted after 24 to 48 hours of antibiotic initiation. And children with scarlet fever, they cannot go to the daycare center or to the school until they have completed 24 hours of antibiotic therapy and they had a clinical improvement. Okay, and then we move on to the acute rheumatic fever. Acute rheumatic fever, it is a sequela of streptococcal infection, typically following 2 to 3 weeks after group A streptococcal pharyngitis. And acute rheumatic fever, it can develop if the strep throat or the scarlet fever
Not
are
just
not treated properly.
pharyngitis, not just pharyngitis. Basically, following streptococcal infection, whatever lah. You can have infection in your throat, pharyngitis. You can get tonsillitis. You can get skin infection with impetigo. So the issue is streptococcal infection. It doesn't really matter is it pharyngitis or anywhere.
Okay, that's the thing. Following any infection due to streptococcal infection. So this acute rheumatic fever, they will have rheumatologic, cardiac, neurologic, and skin manifestation. And also the peak age is also the same as scarlet fever. The peak age is 5 to 15 years old, and it is common in female, and it is uncommon in infant and also children aged 3 years and younger. The risk factor is also much more the same as the scarlet fever. And then we move on to etiology and pathophysiology. So acute rheumatic fever, it is the result from the body's immune response to a throat infection. It is not directly due to the infectious agent itself. It starts with the infection by streptococcal pathogen, where this infection by streptococcal pathogen, they will induce tissue damage, which then will cause inflammatory response, and then a lot of macrophage and also neutrophil arrive at the damaged area. So this will activate innate immune system, where the macrophage and neutrophil will engulf this pathogen, and then they can present the antigen on the surface, MHC class 2. And then they will activate adaptive immune system, where T helper cell can recognize the MHC class 2 and then react with the antigen, to become activated. So there will be production of cytokine, a lot of cytokine, and also T cell can activate B cell to stimulate to be stimulated. So B cell will be proliferated and differentiated, become plasma cell, and this plasma cell can produce antibody. So this antibody, it is antibody specific for the infectious agent, for the streptococcal pathogens. So by this is the importance where our body protein, of our body protein mimic the epitope on the antigen, which will more focus on the M protein and also the carbohydrate cell wall antigen. So when there is a molecular mimicry, so the antibody that originally attack the pathogen, they also can attack our body protein through cross reactivity. So they can lastly they can damage the particular protein. So that's what we and for the joint manifestation, it is usually an early manifestation. It occurs in 75 to 80% of the cases, and they will have inflammation of the synovial joint, and usually it will involve larger synovial joint, for example, knee joint, shoulder joint, hip joint. So the important characteristic here is painful migratory polyarthritis. So it will become painful, and it can affect more than one joint, but it is it's migratory, which means that, for example, it affects the right knee joint, and then for a certain period, this inflammatory synovial joint at the right knee joint will resolve, and then it will migrate to the left knee joint. So that is meant by painful migratory polyarthritis. And then for the height, this it can affect all the layers of the heart, pericardium, myocardium, and endocardium, which we can call pancarditis, and it occurs in 50 to 60% of the cases. And consistent and recurrent attack of rheumatic fever, lastly, can lead to rheumatic heart disease. So for pericardium, we said that it can affect pericardium. So pericardium, there is a visceral and parietal layers. So when these two layers are inflamed, so they can rub against each other during systole and diastole. So here we can listen here to the pericardial friction rub on auscultation, and this rubbing against each other also can lead to chest pain, can cause chest pain. And for the myocardium, when there is an inflammatory response there, so there will be necrosis, so there will be contractility problem. The heart cannot contract properly because there is necrosis there, and then ultimately it can lead to congestive heart failure. And for the endocardium, especially we'll focus more on the valve, so there will be rheumatic vegetation, and when this occur over time, they can stimulate fibroblasts and then produce collagen and also fibrous tissue, which cause the valve to become thicker. And then the valve can become, there will be stenosis and regurgitation of the valve. So patient can present with the sign and symptom of mitral and aortic stenosis as well as mitral and aortic regurgitation, because usually it will affect the left side of the heart, and usually it will affect the mitral valve compared to aortic valve. So patient can present with cardiomegaly, murmur, mid diastolic murmur or pansystolic murmur, dyspnea or atrial fibrillation. So you can focus more on the sign and symptom of this. And then for the brain, we have a basal ganglia. So this basal ganglia, it involved in the direct and also indirect pathway, which help to control our movement. So when this basal ganglia is affected, our movement will be uncontrolled. So patient can have Sydenham's chorea, where there will be rapid, irregular, aimless, involuntary movement of the extremities, trunk, and facial muscle. So it is occur in 30% of the cases, and this Sydenham tachycardia disappear with sleep, and it can be associated with emotional lability, where the patient will have restlessness and outbursts of the inappropriate behaviors, including crying. And then for the skin, they will focus on the erythema marginatum and also subcutaneous nodule. So erythema marginatum, it is an annular concentric ring-like rash and non-pruritic. So it often occur in the extremities and trunk. And for subcutaneous nodule, it is a small painless and round nodule and often over the bony prominence or extensor surface of the body. So this is the example of erythema marginatum, Sydenham's chorea, and also subcutaneous nodule. And part of that, patient also can present with fever, high grade fever, and also arthralgia, which involve in the several joint in a pattern similar to that polyarthritis. And then patient can also present with lethargy, tachycardia during sleep, and also abdominal pain and epistaxis, but these two are rare. And then how we want to evaluate and diagnose this acute rheumatic fever is the diagnosis also mainly based on the clinical manifestation and supported by the laboratory test. So we will diagnose it using Jones criteria. So Jones criteria, we will have major criteria and also minor criteria. So major criteria, this Jones criteria, it also will take into account the low risk and high risk population. So for major criteria, we have joints where it is a migratory polyarthritis. But for low risk population, it must be polyarthritis. But for high risk, the monoarthritis also acceptable. And for the height, there will be carditis, clinical or subclinical. Subclinical means that there is evidence of regurgitation on the echocardiography in the absence of evidence on auscultation. And then nodule, subcutaneous nodule, erythema marginatum, and Sydenham's chorea. And then for the minor, also we divide it into low risk and high risk. Where low risk, there will be polyarthralgia. High risk, there will be monoarthralgia, and then the fever more than 38.5, fever more than 38. And then the ESR and CRP more than 60 and 3. And for the minor, ESR more than 30 and CRP more than 3. And prolonged PR interval for both population, low risk and high risk population. And in order to diagnose, patient must have two major criteria, or patient can have one major and two minor, supported with the laboratory evidence of preceding group A streptococcal infection, where we can do a laboratory test to detect the elevated or rising streptococcal antibody titer. Like I had said before, the anti-streptolysin, anti-hyaluronidase, and then positive throat culture for group A beta hemolytic streptococci, and also positive rapid group A streptococcal carbohydrate antigen test. And then for the other test that we can do is full blood count to check for the leukocytosis, and then this acute phase return to check for the CRP and ESR, and then echocardiography to assess whether there is carditis, to assess for the subclinical carditis, and then electrocardiogram and chest radiograph may also reveal cardiomegaly. And then for the treatment and management, we need to treat to eradicate the streptococci infection using this intramuscular benzathine penicillin G or oral penicillin, and also oral cephalosporin as the alternative for patients who are allergic to penicillin. And also we can give them anti-inflammatory agent to suppress the inflammatory response in joint and heart. For example, we will give them high-dose aspirin, salicylate, and also corticosteroid such as prednisolone. And also if the patient had carditis and severe, so we can give them digoxin or diuretic or ACE inhibitor. And for the Sydenham chorea, usually the first line drug we will give is valproate or carbamazepine, and also we can give neuroleptic like haloperidol. And also we need to give them secondary prophylaxis to prevent this recurrent of rheumatic fever. Uh, we give the same as medication that we give for eradication of streptococci, but for IM benzathine penicillin G, we need to give them every 4 to 3 weeks, every 3 to 4 weeks. So that's how we manage this patient. And then this is okay. That's all for me. So this is my reference. Thank you. So any question?
Any question to the presenter, not to me?
I guess no.
Faham dah. Okay, ke tidur pula ke? Lapar dah. Alright, fine. Next. Ada berapa presenter ni?
5 semua, Doktor.
Ya, Allah, banyaknya. Okay, alright. Fine.
Okay, Assalamualaikum. My name is Siti Nuraisha. So, I'll continue today's presentation discussing about systemic lupus erythematosus, or in short, SLE. Next. Okay, this is the content of my presentation. So, we will be discussing starting from the introduction and epidemiology and last with the prognosis. Next. Based on Nelson's textbook of pediatrics, SLE is defined as a chronic autoimmune disease characterized by multisystemic inflammation and the presence of circulating autoantibodies directed against self-antigen. The severity ranges from mild to life-threatening, and onset can be insidious or acute. Although SLE affects primarily women of childbearing age, approximately 5% of cases present in childhood, mainly around puberty. Female-to-male ratio is about 5 to 1, and only 15 to 20% of SLE patients occur before the age of 18 years old, and SLE is rare in children younger than 5 years old. Next. The etiology of SLE is unknown, but several factors likely influence risk and severity of disease, including genetics, hormone, and environmental exposure. For genetics, it is suggested by the association with specific genetic abnormalities, including congenital deficiency of C1q, C2, and C4. In addition, certain human leukocyte antigen types, HLA, occurs with increased frequency in patients with SLE. Patients with SLE often have family members, especially mothers and sisters with SLE or other autoimmune disease. And because SLE preferentially affects females, especially during their reproductive years, it is suspected that hormonal factors are important in pathogenesis, and estrogen are likely to play a role in SLE, and studies suggest that estrogen exposure promotes B cell autoreactivity. And environmental exposure that may trigger the development of SLE remain unknown, but certain viral infections, including Epstein-Barr virus, may play a role in susceptible individuals, and ultraviolet light exposure is known to trigger SLE disease activity. Drugs such as procainamide and hydralazine can promote lymphocyte hypermethylation, causing a lupus-like syndrome. Next. For pathogenesis, a hallmark of SLE is the development generations of autoantibodies directed against self-antigen, particularly nucleic acid. SLE skin cells are highly susceptible to damage from UV light, and the resulting cell death leads to release of cell contents, including nucleic antigens. Individuals with SLE may have increased levels of apoptosis or significantly impaired ability to clear cell debris, and causing prolonged exposure to nucleic antigens in the bloodstream and increased opportunity for recognition by immune cells, leading to B cell stimulation and autoantibody production. Circulating autoantibodies form immune complexes and deposit in tissues, leading to local complement activation, initiation of a pro-inflammatory cascade, and ultimately tissue damage. Next. Okay, this diagram simplifies what I already explained. You may take a look again after this. Next. Okay, for clinical manifestation of SLE in general, childhood SLE is more severe disease when compared to adult SLE, and often presenting with severe renal, cerebral, and hematological manifestation, and with a higher overall disease activity resulting in more long-term morbidity and mortality. Non-specific symptoms are common, but can be quite profound and may include significant fatigue, anorexia, weight loss, and low-grade fever. Arthritis and arthritis are common. The arthritis is rarely deforming and typically involves the small joints of the hand. Skin diseases can be a prominent finding occurring in majority of patients. Mala and discoid rash are common. Mala rash is erythematous rash, while discoid rash is a permanent scarring and loss of pigmentation in the affected area. Oral and sores resulting from mucosal ulceration are common complaint in patients with SLE. And renal involvement is one of the most serious manifestations of SLE and is common in pediatric SLE. And renal disease may range from microscopic proteinuria or hematuria to gross hematuria, nephrotic syndrome, and renal failure. Hypertension or the presence of edema suggests lupus renal disease. SLE can also affect the CNS, leading to symptoms ranging from poor school performance and difficulty concentrating to seizure, psychosis, and stroke. And because of reticular endothelial system stimulation, lymphadenopathy and splenomegaly are common findings in SLE. And SLE is a disease that evolves over time in each affected individual, and new manifestations arise even many years after diagnosis. Next. These are some pictures of mucocutaneous manifestation in SLE patients. As you can see, there are malar rash, vasculitic rash, oral ulcers, alopecia, and discoid lupus. Next. Here. Diagnosis is based on the presence of clinical features supported by positive laboratory findings. And criteria for the classification of SLE is based on the European League Against Rheumatism / American College of Rheumatology. For this criteria, one must meet the entry criteria, which is the presence of anti-nuclear antibodies (ANA), and this ANA is very sensitive, but it is not very specific. And it requires at least one clinical criteria, as you can see in the table, and total of equal or more than 10 points for both clinical and immunological criteria. And only the highest criteria in a given domain counts. For example, a patient has fever, acute cutaneous lupus such as malar rash and oral ulcers, means that she has two criteria for mucocutaneous domain, but we need to choose only one criteria that has a higher point, which is the acute cutaneous lupus, and add with the fever point. And for your information, there are other antibodies which are more specific for SLE but not sensitive, which are the anti-double-stranded DNA antibody and anti-SMACE antibody. Next. Okay, for other laboratory investigation, we can also request for FBC, serum C3 and C4, ESR, and CRP for inflammation, urinalysis, and renal profile to evaluate kidney function. And some have been mentioned in the previous slide. Okay, so for FBC anemia may occur due to chronic disease, and excessive circulating antibodies and immune complexes also lead to consumption of complement protein with low levels of C3 and C4 and decreased complement function, but often improve with treatment. Urinalysis may show proteinuria and hematuria, identifying a patient with lupus and nephritis. A renal profile may also reveal increased serum creatinine. Inflammatory markers, particularly ESR, are often elevated in active disease. CRP correlates less well with disease activity, and significantly elevated CRP values often reflect infections. Okay, for other organ assessment, we can also request for chest X-ray, echocardiogram, renal biopsy, and many more. Next. Okay, for differential diagnosis, multi-organ disease is the hallmark of SLE, given its wide array of potential clinical manifestations. SLE is in the differential diagnosis of many clinical scenarios, including unexplained fevers, joint pain or arthritis, rash, cytopenias, nephritis, nephrotic syndrome, pleural or pericardial effusion, or other cardiopulmonary abnormalities, and new onset psychosis, movement disorder, or seizures. Before patient ultimately diagnosed with pediatric SLE, the initial differential diagnosis often include infections such as sepsis, EBV, parvovirus, and endocarditis, malignancies like leukemia, lymphoma, post-traumatic glomerulonephritis, other rheumatological conditions such as DIA, vasculitis, which is a group of autoimmune disease that cause blood vessel inflammation, and also drug-induced lupus. Next. Yeah, for the management, the aim are to achieve a reduction and control of disease activity to prevent long-term organ damage, to maintain health and function, and aid patient and family to cope with disease and treatment, and also to minimize side effects of treatment. Generally, patients with SLE should be counseled to wear sun protection such as sunblock and avoid sun exposure, because exposure to the sun precipitates flares of the disease. Because of this prohibition, patients should have adequate nutrition, especially dietary intake of calcium and vitamin D, to reduce the risk of osteoporosis that may result from prolonged corticosteroid usage. Any infection should be treated promptly and aggressively. All routine immunizations are recommended, but live vaccinations are contraindicated if on immunosuppressive agents. Additional vaccination can be given, especially against pneumococcal infection and influenza. For corticosteroid, it is usually required by all children, even in the absence of major organ involvement. Prednisolone orally or methylprednisolone intravenously can be given, and tapering of steroid dose should occur once disease is controlled, aiming for lowest possible dose, and the rapidity of steroid taper depends on clinical response, control of disease activity, and towards normalization of laboratory findings. For immunosuppressive agents, it is now started early soon after diagnosis for rapid control of disease with better long-term outcome and as a steroid-sparing agent. The choice of immunosuppressive agents is highly depends on the organ systems involved and the severity of the involvement. For example, azathioprine, especially used for hematological cirrhosis, vasculitis, and sometimes as a maintenance therapy for lupus and nephritis. Others are methotrexate, cyclosporine, cyclophosphamide, and MMF. Next. Okay, other pharmacological therapy is hydroxychloroquine. It is an anti-malarial drug that is recommended for all lupus patients as it can help reduce flares, reduce autoantibody production and cardioprotective. And hydroxychloroquine is also useful for mild arthritis and skin disease. And patient who is on this drug needs yearly eye screening and hearing assessment because it can cause retinopathy and ototoxicity. This drug usage should be cautious in impact renal function and consider to stop the medication as increased risk of toxicity. Others are NSAIDs for myalgia, arthritis, and psoriasis, calcium and vitamin D for bone health, antihypertensive agents as required in lupus nephritis, and low dose aspirin for those with significant titers of antiphospholipid antibodies, heparin followed by warfarin in the presence of thrombosis. IVIG sometimes used in ill children in whom the possibility of severe infections cannot be excluded. And the current used biological agents for resistant cases include rituximab and belimumab. Both of the drugs are monoclonal antibodies. Okay, lastly, for the follow-up, at every clinic visit, assessment should be done to look for evidence of active disease by doing detailed systemic assessment and complete physical examination. Look also for complications of disease or treatment, any psychological issues like school issues, bullying, and family support. We also need to assess the compliance to treatment regimen. And some investigation can also be done to support assessment adjust treatment and look for complications. Next. Okay, for complication, within the first several years of diagnosis, the most common causes of death in SLE patients are infection and complications of glomerulonephritis and neuropsychiatric disease. Over the long term, the most common causes of mortality are complications of atherosclerosis and malignancy. Increased malignancy rates may be caused by immune dysregulation as well as exposure to medication with carcinogenic potential. And this table shows the complication of morbidity in childhood lupus based on the system. Next. Okay, lastly, for prognosis, outcomes for SLE have improved significantly over the past several decades and depends largely on the organ systems that are involved. Worse prognosis are seen in patients with severe lupus nephritis or cerebritis with risk of chronic disability or progression to renal failure. And with current therapy for the disease and success of renal transplantation, however, most patients live well into adulthood. I think that's all from me.
Any question? SLE is very, very common. It's so easy to make questions. It always comes out for usually theory exam. It's a very good, so many things we can ask. So many things. And it comes with even because SLE can cause nephritis, for example. So when we discuss about nephrotic, we'll discuss about SLE as well. We can discuss about steroids. There's so many things we can discuss. So common.
I have a question.
Yeah.
For SLE, is it a lifelong disease, which means that the patient never fully recovers from it and always require treatment if there's any like acute episode of SLE?
Okay. Since SLE, one of the risk factor is congenital. Um, it mainly because of the presence of circulating autoantibody. And the treatment. Some patients may need treatment for the whole life because the patient has that autoantibody that directed against own cell.
So this means that most patients don't fully recover, is it?
Yes.
Okay.
Because yeah, there must be there must be uh, episodes of a flare. So
Okay, thank you.
Okay. Any other questions? Clear? Again, SLE is very, very common. There's so many complications with SLE. There's so many things. Okay, alright, fine. Next. Kalau semua dah faham, semua clear, semua ready nak jawab soalan nanti.
Okay, Assalamualaikum. I will proceed with the juvenile idiopathic arthritis. Okay. So this is my outline. So juvenile idiopathic arthritis. So the name itself, we can understand what is it, which is juvenile means young, idiopathic means disease with unknown causes, while arthritis the inflammation of the joint. But a proper definition for the GIA is the persistent joint swelling of more than 6 weeks duration, presenting before 16 years of age and in the absence of infection or any defined causes. So, GIA is the most common chronic inflammatory joint disease of childhood in UK, with the prevalence of 1 in 1,000 children, and is more common in girls more than boys. So, for the etiology, the cause is actually unclear, but it can be associated with the alterations in both humoral and cell-mediated immunity. And the common underlying manifestation of this illness is the arthritis or the presence of the inflammation of the joint synovium. So when the synovium become thickened and hypervascularized with the infiltration of lymphocyte and pro-inflammatory cytokines such as TNF alpha, interleukin 1 or interleukin 6. So this will lead to tissue protease and collagenase production. And if this left untreated, this will lead to tissue destruction, particularly articular cartilage, and eventually it will affect the bone structure itself. So this is the classification of the GIA. International League of Associations for Rheumatology, ILA, has classified GIA into these several types. So firstly, we need to differentiate between oligoarthritis and polyarthritis. So oligoarthritis is when it involves 4 or less joints. Polyarthritis it involves more than 4 joints, which is 5 onwards. And oligoarthritis, we can further subdivided it into 2 oligoarthritis, which are persistent and also a standard oligoarthritis. For persistent, it means that it refers to children with 4 joints or less that in the first 6 months, and then it do not develop of more than 4 joints.
Oligoarthritis ni, dia ada satu lagi term lain kita panggil palsy articular, which is the same thing lah. Oligo means less, palsy is also means less lah, PAUCI. So palsy articular is same as oligoarthritis lah. So sebab kalau you buka certain paper, certain textbook, they use palsy articular. Okay, alright, fine, proceed.
Okay, so the standard arthritis, which means that the joint disease has evolved more than 4 after the first 6 months. So that's how it became standard oligoarthritis. So this oligoarthritis, the age onset is about 1 to 6 years old, and it affects 5 times in female more than male. And also it has extra-articular features, which is chronic anterior uveitis. And for polyarthritis, we can subdivide it into 2, rheumatoid factor negative and rheumatoid factor positive. This articular pattern in the polyarthritis is it affects symmetrical large and small joint arthritis, which means that if it's affect your wrist joint in your right hand, then it will affect your left hand too. And this rheumatoid and if the rheumatoid factor is positive, then it means that you have poorer prognosis in the patient. So for systemic arthritis is characterized by arthritis with fever, rash, and also commonly involve the hepatosplenomegaly and also lymphadenopathy. And the fever of the systemic arthritis has its own characteristics, which are it has spiking more than 39 degrees Celsius, which is high grade fever, which occur daily, and it has a rapid return to the normal temperature for the rest of the day. And this fever usually accompanied with the pink salmon rash. I will show the picture later. That often we found at axilla or also around the waist, but this rash may occur anywhere in the body. And the onset of the systemic arthritis is 1 to 10 years old, and it affects equally male and female. So next one is psoriatic arthritis. So this one it affects equally male and female, and this occur when is a form of arthritis that affects people that have psoriasis, which is a skin disorder that cause skin cell to multiply more than 10 times more than normal. So that's made the skin build up in quite a bumpy patches with white scales. And also on the next one is enthesitis related arthritis. So this one other than having arthritis, it also has enthesitis, which are the inflammation of the enthesis, which is a connective tissue that where the tendon and the ligament attach to the bone. And if it is and it is strongly associated with the SLA B27 plus. For the last one, undifferentiated arthritis, this one when the arthritis does not fail any criteria in the category I mentioned, and also when it's fulfill more than 2 category that I mentioned before. So for the clinical manifestation, I divided into articular and extra-articular. For articular, the patient may come with joint stiffness and also gelling, which is the stiffness of the joint when the after a period of rest, such as after a long car journey. And also, patient also can come with joint swelling, either with pain or not. And there is signs of inflammation such as joint warmness or also erythema and effusions. And there is also restricted joint movement because of the pain or the swelling itself or because of the contracture as its lack of use. And there is also abnormal gait such as limping gait. So in extra-articular, systemic GIA, they will commonly have systemic signs and symptoms such as fever, pallor, anorexia, and loss of weight. And there is a growth disturbance as a complication of this illness, growth failure, and also limb size discrepancy, which is unequal limb length, and microatia. So in the skin itself, there will be subcutaneous nodule or rheumatic nodule, which presents in the positive rheumatoid factor polyarthritis, and there is a salmon pin rash. I provide the picture. So this salmon pin rash occur in systemic GIA, and also nail pitting. Nail pitting is a sign of psoriasis, I guess. And nail pitting is shallow or deep hole in your nail. So and we can find hepatomegaly, splenomegaly, lymphadenopathy, psoriasis, also uveitis. So this uveitis, which is the inflammation of the uvea, which is the middle layer of your eye, which consists of iris, ciliary body, and choroid. So for differential diagnosis, GIA is a diagnosis of exclusion. So the diagnosis of GIA is established by the presence of arthritis, duration at least 6 weeks, and also with the exclusion of this other differential diagnosis. So for example, SLE. SLE also can cause arthritis. So when there is the presence of other autoantibody other than ENA, such as double-stranded DNA or Smith antibody, so this will suggest SLE rather than GIA. And also malignancy, such as leukemia. So how to differentiate leukemia is more severe pain at the joint or also bone pain. And also the pain and swelling in leukemia is can change place when before we feel the pain at the arm and then later at the leg, but in GIA usually the pain does stay there. This does not change place. So okay, for the investigation, as I said that GIA is a diagnosis of exclusion. So GIA is a clinical diagnosis without any diagnostic laboratory investigation. And this laboratory investigation is only for supportive or also prognostic and also to exclude the other differentials. The first one is full blood count or peripheral blood flow. We can do to exclude leukemia with the presence of elevated white blood cell, and we could check the anemia or the chronic disease. And the anti-nuclear antibody, which if it's positive, then we should remember that it can increase positive anti-nuclear antibody will increase the risk of uveitis. So it's quite important. For the erythrocyte sedimentation rate or C-reactive protein is an inflammatory marker, so it's elevated in inflammation. And rheumatic factor also is very important to assess the prognosis of the polyarthritis and the need for more aggressive therapy. For X-ray, for X-ray of affected joint, usually the early stage we could not find any abnormality in the X-ray, so the bone will be normal. But over time, we can see periarticular osteopenia, which result from decrease in the mineralization. So periarticular osteopenia indicate post-inflammation. So this kind of midpoint between healthy bone and also osteoporosis. And the late stage, we can find the erosion of the bony articular surface itself. And others investigations such as anti-streptolysin O titer to exclude acute rheumatic fever, as it can also cause arthritis, and complement levels to exclude SLE. So for management, the aim of management in GIA is to suppress the inflammation, preserve maximize function of the joint, prevent deformity, and also prevent blindness. And is divided into pharmacological and non-pharmacological management. So for non-pharmacological management, there is 5 of them. So the first one is physiotherapy. So this aims to avoid prolonged immobilization and to improve the muscle strength. And physiotherapy can also improve balance in the patient and for cardiovascular fitness. The second one is occupational therapy. For occupational therapy, we can do sprinting when necessary to reduce the pain and reserve the joint alignment. Because sprint is a device that maintains the joint position. The third one is we need to refer to ophthalmologist because for uveitis screening. And if the initial, even if the initial screening is normal, so we need to do follow up at the ophthalmologist because uveitis at the early stage it can be asymptomatic. Next is psychosocial. This to improve self-esteem in the patient. We can give counseling and family support is also important. The next one is nutritional support, which is we can give calcium supplement or vitamin D supplement to prevent the osteoporosis. Okay, the next one is the pharmacological treatment. Okay, the first one we can give NSAIDs such as naproxen or ibuprofen. So NSAIDs, itself does not modify the disease, but it help relieve the symptom during flash, and it show improvement in the inflammation and pain. But for those with no or partial response after given M6, we should give a intra-articular injection of the corticosteroid. So this such as triamnicolone. So this is the first line treatment in oligoarticular GIA, and it is also used as bridging agent when starting methotrexate in polyarticular disease. Okay. So next one is immunomodulator or DMARDs, which is the disease modifying anti-rheumatic drug, such as methotrexate and sulfasalazine. And immunomodulator is a treatment of the disease by activating or suppressing the immune system. So this is the second line drug treatment given to children with persistent or severe arthritis. And if we give it early use, it will reduce the joint damage. But however, it is less effective in the systemic features of GIA. So if the patient does not get better even with the immunomodulator, we need to give it biology agent, such as TNF alpha antagonist, interleukin 1 inhibitor, and also interleukin 6 receptor antagonist. So all of these will inhibit the pro-inflammatory cytokine. It's quite useful in the severe disease that resistant to methotrexate. So for complication of GIA, the first one is chronic anterior uveitis, which is a common complication but is asymptomatic in early stages. But if this not detected, if it not detected and treated early, it can lead to severe visual impairment. So that's why they need to give the patient need to get a regular ophthalmology screening using a slit light lamp. I think what I read, especially in child that have oligoarthritis with positive ANA. Okay. So next one is growth failure. Usually it is generalized with material factor, usually because of the chronic diseases, anorexia, and also because of the systemic corticosteroid therapy. But in this growth failure, we can prevent it early with early diagnosis and also treatment. For next one is flexion contracture of joint. So this is a band of flex joint that cannot be straightened actively or passively. So okay, so the next one is osteoporosis. Osteoporosis also from the multifactorial reason because of the diet of the patient or also because of the systemic corticosteroid therapy. And we can prevent this osteoporosis with the vitamin D supplement and or calcium supplement, or also minimizing the corticosteroid therapy. Okay. So for prognosis, overall prognosis in TIA is quite excellent with 85% achieve remission. Articular GIA tend to do well, whereas polyarticular and systemic onset GIA mostly have functional disability. And children with systemic onset, positive rheumatic factor, poor response to therapy, and also there's erosions on the X-ray findings will have poor prognosis. Okay, that's all for me. This is my reference.
Any questions to the presenter? So sometimes JIA, we follow up the patient up to sometimes almost 30 years old. I have one patient, I think we follow up until 20 something years old. And then actually I saw the patient when she was working in Mesra Mall in Dungun. That's quite interesting.
I mean, you followed the patient a long time ago and you found her working in Mesra Mall?
Yeah.
Wow.
It's interesting. Okay, any question? Another question? Last kan, habis kan?
Satu lagi doktor.
Oh, ada lagi? Ada berapa lagi?
Satu lagi.
Macam banyak dah pula. Okay lah, alright. Fine. Let's proceed with the next.
Can you see my slide?
Yes.
Okay. Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. My name is Faizan Rafika binti Firdaus. I will be the last presenter and I will be presenting the topic Hinak Shanlan Purpura. Okay, so this is the outline of my presentation, where I will be explaining from the introduction, pathogenesis, and up until the prognosis. Okay, so for the introduction, Hinak Shanlan Purpura is defined as a vasculitis, which is inflammation of the blood vessels, and it involves the small vessels of the skin, the joints, kidneys, and gastrointestinal tract. Hinak Shanlan Purpura is also known as IgA vasculitis because it is characterized by immunoglobulin A, IgA deposition in the small vessels. But the name is actually, the name Hinak Shanlan is actually after the name of a German pediatrician, which name is Edward Heinrich Hinak, and also his teacher, who is Johann Lucas Schaunlein, who have described the association between purpura and arthritis and also gastrointestinal involvement. So how does Hinak Shanlan Purpura occur? Actually, the exact pathogenesis of HSP is unknown, but it is found that most cases were preceded by upper respiratory tract infection. So multiple case studies have proposed the correlation between respiratory pathogens and the development of HSP. And the other contributing factor found is genetic component, because the HSP occasionally clusters in families, and there have been studies that shown there is increased risk of development of HSP in children who carry certain human leukocyte antigen. Okay, as for the epidemiology, HSP is the most common systemic vasculitis in children. It occurs worldwide and affect all ethnic groups, but is more common in Asian and white population. HSP also affect males more than females. It occurs more common during the winter. 90% of cases occur in children with the age of around 3 to 10 years old, and the incidence is 14 to 20 out of 100,000 children per year. Okay, as for the pathogenesis of HSP, as I said before, the exact pathogenesis is unknown, but it is hypothesized that genetics and environmental factors are the trigger that cause the development of HSP. So for respiratory infection, some of the infectious triggers found to be associated is group A beta hemolytic Streptococcus, Staphylococcus aureus, Mycoplasma, and adenovirus. And how does this lead to the development of HSP? Is that the hypothesis is the the pathogens that cause the infection share the same antigenic structure as the antigen that are present on the endothelial cells of the blood vessel wall. So when these pathogens cause infection, it will cause the release of IgA, which is supposedly fight off the infection, but accidentally also bind to the antigen on the endothelial cells because of the molecular mimicry. So when it binds, this will lead to the production of immune complexes that will then deposit on the blood vessel walls. And this will cause inflammation due to production of interleukin-8 and also cause infiltration of polymorphonuclear cells, which in the case of HSP is mainly neutrophils. And apart from causing inflammation of the small vessels, this also lead to the leakage of blood from the small vessels under the skin. So this causes subepidermal hemorrhage and manifests as purpuric rash, or which can be seen as red or purple lumps under the skin containing blood. So this condition is IgA vasculitis. And also, apart from causing damage to the vascular wall, the immune complexes can also bind to the messenger cells in the kidney and lead to inflammation of the glomerulus and also impair renal function. So IgA vascular nephritis also can occur with HSP. This is just a diagram that shows inflammatory process that occur in HSP. Okay, so for the clinical manifestation, HSP is characterized by a classic tetrad consisting of palpable purpura, arthralgia and arthritis, abdominal pain, and renal involvement. So the hallmark of the disease is palpable purpura, which is the rash that is commonly symmetric, occurs in both sides and more in the gravity-dependent area, which are the legs and the ankles, and also seen on the buttocks. And this rash typically lasts for about 3 to 10 days and may recur up to 4 months after the initial presentation. The next manifestation is arthralgia and arthritis. These occur in up to 75% of cases where the joint pain commonly affect the knees and the ankles and typically will resolve in within 2 weeks, but it can also recur. And next is GI manifestation, gastrointestinal manifestation, occurring in up to 80% of cases. Usually there would be abdominal pain, which is colicky and in nature, and it can also occur with GI bleeding, which is hematemesis and melena. And the last one is renal involvement, which occur in 30% of cases and manifest as hematuria, proteinuria, nephritis, and hypertension. Okay, so the diagnosis of HSP is clinical and straightforward with the presentation of purpuric rash. And this table shows the classification criteria for HSP by the Pediatric Rheumatology European Society. So the criteria is that there must be palpable purpura with the absence of either coagulopathy or thrombocytopenia. And there must be one or more of the following criteria, which are abdominal pain, arthritis or arthralgia, biopsy of the affected tissue that demonstrate predominant IgA deposition, and renal involvement. So this picture shows the positive IgA immunofluorescence in the skin biopsy of HSP. As for the laboratory findings, it is not diagnostic, but there are several common and non-specific findings. So the first one is from food blood count. We might see mild anemia, which is normochromic and normocytic. That might be due to the GI bleeding. And leukocytosis is due to the infection. And next is ESR and C-reactive protein, which is elevated, indicating the inflammatory process. Serum albumin would be low due to renal protein loss. Renal profile shows elevated urea and creatinine. And urinalysis will be hematuria and proteinuria. And serum IgA is most cases cause elevation of serum IgA. Okay, so for the treatment of HSP is a mild and self-limiting disease. So the treatment would be symptomatic and supportive, which is by ensuring adequate hydration, nutrition, and analgesia. For example, for acute arthritis, short-term course of NSAIDs can be initiated, and only if there is significant involvement of GI or renal. The most often medication used is systemic corticosteroids, which is given to reduce the duration of the symptoms, but it has no effect on, it cannot improve the long-term outcome of the disease. As for the complications of HSP, for GI involvement, HSP can become the risk to cause intussusception and intestinal perforation. So intussusception refers to the invagination of one portion of the intestine into another portion, and this is due to the submucosal hemorrhage and edema that occurs due to HSP in the GI tract. And another complication is renal involvement, which may lead to renal failure. But this is rare. It occurs in only 1 to 2% of cases. So it is recommended for children with HSP to undergo serial monitoring of blood pressure and urinalysis for at least 6 months after the diagnosis to monitor for any renal complication. Okay, so for the prognosis of HSP, it is excellent. most children will most children experience acute self-limiting course that lasts for an average of 4 weeks. But in 15 to 60% of cases, there is one or more recurrences. But the symptoms during the recurrence is milder compared to the one during presentation. And the long-term prognosis will depend on the severity and duration of any GI or renal involvement. Okay, that's all from me. Is there any question?
Anything? Any questions? Inoxon line can come in your clinical exam because sometimes the symptoms persist for a few weeks. So if we have new patients with the findings, we can just call them, and it should be that again. There's a lot of discussion to do as well, because there can be joint involvement, there can be GI involvement, there can be renal involvement. All this you can ask easily in the exam. Again, theory and also clinical. Extra with this one, because clinical we can call, because they usually are quite well. They don't usually present in an ill condition. So there's so many things we can ask. And also we can discuss about HSP from AGN. So if we have patients with AGN, we can easily swing towards discussion regarding induction line purpura as well. Okay. Anything else?
Nothing else.
Semua faham lah ke? Semua dah ready to jawab in exam. Okay, fine. That's good. Alright. Okay, I think if that's all. Tak ada question clear okay, let's end our session with tasbih kafarah surah Al-As.